All right. So today, you guys all know who I am, but I'm Laura Goldberg. And today we're going to talk about stress fractures. Please interrupt me at any point if you have questions, comments, or anything. There it goes. All right. We're going to try and review a lot about stress fractures and really kind of how to manage them through every stage of it. So stress fracture, I like to explain to patients, it is either an abnormal repetitive load on normal bone, so the micro damage is what leads to the fracture, versus an insufficiency fracture, which is a normal load on pathologic bone. And they can kind of appear similarly at first. And it's our job just to really make sure that we're treating the right thing. So that repetitive stress causes adaptation on the bone, and when the repetitive stress exceeds adaptability, that's when you get the bone breakdown, which then causes a stress fracture. When we think of stress fractures, I think because of what we do, they seem to be a lot higher incidence than they are, but there's really no clear estimate of who has them, because a lot of times they're not diagnosed, or they're overdiagnosed because they might just be shin splints or something. But some studies have shown 1.5 to 100,000 in high school versus a higher number in college athletes of 5.7 per 100,000. Most of the studies that have been done have been in military recruits, as you can imagine, as well as in college Division I. So still a good percentage, and I think the better we get, hopefully we'll see less of that because we'll start to prevent more. So what can we control? Well, we have intrinsic risk factors of making sure that you're eating right, you're sleeping well, that we identify any metabolic bone disorders and treat them, any collagen abnormalities, and then also that hormonal imbalance. And that can be something that is, innate, or it can be something that is occurring because of poor nutrition or over-exercising. In terms of the extrinsic factors, it's really important to recognize certain sports are at higher risk than others, the type of training they're doing, looking at the change in training, what surface they're training on. And, something that we don't give enough time to in clinic and all is recovery time. It's a really important part of training that needs to be kind of talked about more, I think. And then making sure that they have appropriate shoe wear, and that when they change shoe wear, it may change the load on their bones, which could then actually lead them to a higher risk. So when we talk about bone health, it's the area that we see the largest growth is in early adulthood. So after menopause, we know it goes down. We know there's a role of genetics, but 50% increase in total bone mass occurs between 12 and 18 years old. And 90% of the bone mass is gained by 18 years old. So, looking at these modifiable factors, we really want to make sure that every person is gaining their best possible bone mass that they can. So when we think about bones, you think about how they're grown. 80% of bone is cortical bone, or that dense, sort of really solid part that's around the inner marrow. And then the inner part is 20% of that is trabecular. I describe it as honeycombing, but a lot of kids don't know what honeycombing is. So sometimes I'll talk about spider webbing or use my fingers to show kind of the crisscross of things. But recognizing that the different types or makeup of bone have different abilities to adapt. So the mechanotransduction is when the osteogenesis responds to variable dynamic stress. So our bones are basically not static. They're constantly changing. And it takes about 3 to 4 months for one full cycle of bone resorption, formation, and then mineralization. And that's why we see that delay on x-rays with fractures. And then the rate depends on the number and frequency of loading cycles. So again, on stress fractures, sometimes people, we want to take them fully off, but that some loading is okay, because that does help the cycle continue. So maladaptation is due to imbalance of bone resorption and formation. So in the clinic, let's talk about how we address them. Generally, the clinical presentation is what leads us to the diagnosis. It's the history, it's the abrupt change in training, inadequate recovery, or cross-training. I like to hear, an insidious onset or gradual onset of pain over days and weeks. When I hear someone say, okay, I was running, I had a sharp pain and now, I'm hurting. I don't think stress fracture, it can happen that way, but almost always it's more gradual. And sometimes you have to dig out that history a little bit because they'll say, oh, it just started. But then you start saying, oh, well, yeah, actually it was a little bit here and there. When they wake up in the morning, they may not have any pain initially. Eventually, once it gets worse, if it's not diagnosed, they're going to wake up and feel great. And the minute they put their weight down, it's going to start hurting. Pain worsens with activity rather than loosening, and it remains after rest. Initially, it only may be a few minutes, but over time, it'll get longer, and then it can get to where it's constant. You may or may not have visible swelling. A lot of times you can feel sort of some edema along the bone when you're palpating, but you may not see it. So it's really, really important to get a good history. Again, specific questions about training, looking for a change in pattern or intensity. Did they add another sport? If they have a training log, it's good to kind of have them review it and look and see where there might have been a change. Again, having the appropriate shoe wear is essential. And not only having appropriate shoe wear, but shoe wear that isn't worn out, that it's replaced appropriately, and that it fits their mechanics. So looking at the bottoms of their shoes, making sure their wear patterns is normal, so that because you want to then look to see how we can prevent it in the future. Nutrition plays a huge part, and just a 3-day diet recall tends to be a good way to look and see what their overall eating pattern is. And if you have any questions or concerns, of course, getting them to nutritionists. Hormonal, getting a menstrual history, making sure that if they've had menarche, if they have not had it, are they still at an appropriate age to not have it? If you haven't had it by 15, well, really, if you haven't had it by 16, so if they're 15 and they haven't had it, you need to start looking and figuring out why. If they've already had it and they're missing periods, how intense are they? How long do they last? Because if you ask if their menstrual cycle is normal, they don't know. I had a girl that I asked if hers was normal. She said yes. And she was going through crazy number of tampons a day, and which is, excessively heavy bleeding. And she had a lot of issues because of that. Looking at other medications they're on, if their period is regular, but they're on hormones, that's not a regular period. That's a hormonally controlled period. Looking for history of thyroid disease in the family or symptoms of them with their own. And then vitamin D is also another important aspect to ask about. So on exam, I always like to get height, weight, and BMI. I think it's an important vital sign especially in our clinics. General exam of lower extremity. I start with them standing, looking at them walking, running if it's available. I don't have great places in my clinics to have them run. Just their overall standing alignment. Range of motion of all the joints involved. So if it's in the shin, I'll look at their knee and their ankle. If it's in their foot, I'll look at their ankle and toes and all that. Strength, any visible deformities. And like I said, a lot of times there's not swelling or anything obvious, but you might see a little light erythema sometimes. And then passive range of motion may not be painful unless it's in the hip. That generally tends to cause pain. And then the more you load it, the more likely you're going to have pain. So I will often challenge them by going double heel raise, single heel raise, double hop, single hop, and I do that first because then more likely it's going to be more tender on exam. And I do expect with a stress fracture to have palpable or point tenderness on the bone in a smaller area. So if you're looking at their bone and they're tender all along, you're probably thinking, oh, this is shin splints or medial tibial stress syndrome. But if there's an area that's really small that's tender, that's when we start thinking more, even if the whole thing is sore and then one sharp area that's consistent. So what do we do for imaging? Well, we get plain films, but it's very low sensitivity because, again, due to the way that the bones form, that first initial resorption and then bone growth doesn't have any mineralization, so you can't see it. Ultrasound is not well studied, but you can sometimes see a little hematoma with periosteal elevation that can suggest that there's something going on there. The 3-phase bone scan is very sensitive, but again, it's not as specific as we would like. And then the MRI has been sort of what we switched to as the gold standard and allows us to have 100% sensitivity and better specificity. It shows fracture lines, edema, periosteal reaction. It can be used for grading return to physical activity. As we go through this, you'll see that most of them are really more of a clinical return anyhow. But so when we look at x-rays, generally you're not going to see anything. If you see a callus formation like this, you know it's been going on for a long time. So this treatment of stress fractures is where I think us as sports medicine physicians can really shine. It's really easy to tell athletes or anyone, oh, if you just stop doing stuff, it's going to get better, right? But I really encourage them, if it's their foot or their shin, I'm like, keep lifting with your upper body, do core stuff, get in the pool and swim, get on a bike. And when you don't have pain biking, get on an elliptical. Keep them active. And so that when they do feel better, that they're ready to go back and they're not, completely deconditioned. I like to say that they have about 2 weeks before they start losing everything. So, maybe the first week they don't do very much at all, but then they better start doing stuff to stay physically in shape for their sport. Look for underlying risk factors, and then think about the treatment factors. So where is the stress fracture? How long have they had the symptoms? How have they responded? What sport are they having, and what competitions they have? And we'll go through these. So different areas of our body have different risks associated with it. The high-risk sites, femoral neck, anterior tibia, sesamoids, base of the fifth, and navicular, they all take more like 6 to 8 weeks. When you talk about metatarsal, fibula, posterior medial tibia, and femoral shaft, those, except for the femoral shaft, because it just is a high load area, they take a lot less. But generally, they take longer than 3 weeks to get back to sport, but you can start weight bearing them a lot sooner. So why are these high risk areas? Most of them are because they have a decreased blood supply and they have an increased tensile load. So if you look at the femoral neck, on the inferior aspect of it, it's going to load when you step. It's closing that fracture line, right? It's putting pressure to keep it together. Whereas it's on the top, it's pulling it apart. Same thing on the tibia. On the anterior tibia, it's more likely to have traction or pulling on it, versus on the posterior medial, it's more compressing. So the dreaded black line is that anterior fracture line on the anterior tibia. Those you have to take very seriously and very conservatively. So in terms of workup beyond treating the stress fracture, the high-risk stress fractures definitely do. And then when you're getting your history, you got to know, have they had any other stress fractures? How are their menstrual regularity? And then have they not been healing? Generally, I kind of give people a pass on their first stress fracture in terms of a full workup, but I always ask about menstrual regulators, and I work up lab work, just initial lab work for vitamin D and ferritin and things like that. And then I always am evaluating for how we can best prevent in the future. So what is the workup? Well, you don't have to get a MRI or bone scan on every patient. It is helpful if it's not clear cut that it's going to be a stress fracture, because as you can see, we need to know if it's a recurrent stress fracture in the future. So if you're not 100% sure that it is, it's helpful to diagnose it just for documentation. Anytime someone has a stress fracture, there has been something that has not been working. So that's why I do the sort of a little bit of investigation, but maybe not full go with any stress fracture. But anytime you have a high risk one, you need a nutrition consult, you need full labs, and then bone density. So we talked a little bit about the different things to do. The pros of an MRI is, of course, you have less radiation, it takes less time, doesn't require an IV, but the bone scan is less expensive, and still some insurance companies prefer it. The MRI staging, they did a study that looked at the different grading, and the higher the grade and the lower the bone mineral density predicted a lower return to sport. So when we're looking at MRIs, grade 1 is just a little bit of that edema along the side of the bone on the T2 weighted area. Grade 2, you're going to see a little bit of hematoma or periosteal elevation. Grade 3 gets into the marrow edema, and you also will see some periosteal edema. And then grade 4 is when you see a marrow edema, periosteal lining, and a fracture line. So the study to assess if staging was relevant in pediatric patients, they looked at a group of patients aged 7 to 18, and about 55 days from diagnosis to full recovery for all 3 stages. And I am guessing those are stages 1, 2, and 3. I realize now that I should clarify that in the future to find out if they studied all of them or if they didn't include the stage 4. The bone scan, when you look at those, and I used to see them all the time. I haven't done one or seen one for a while, but there's 3 phases. So that flow phase is where you get the pre-injection image, and then you inject, and you're looking for about 60 seconds, a bunch of frames, and the flow should be quick and symmetric. When you get to the next phase, it looks at the blood pool phase is how it all accumulates in the soft tissue in the bone. Again, that should be symmetric. The delayed phase, which is about 3 hours after the blood pool, your soft tissue should be cleared out. And then you're going to have some increased uptake in growth plates and joint surfaces where they're really weight bearing. But wherever there's increased osteoblast activity, you're going to see it. So you should see that in like a stress fracture, you're going to see increased uptake in that tibia, and it won't be symmetric unless, of course, they have 2 right there. When we look at the different phases, it's the delayed uptake that we typically see stress fractures. Of course, it's not specific, so there's all sorts of things it can lead to, and you need to make sure that each of these things is looked at in terms of making sure that the bone scan is only in delayed uptake, and if it's there, we need to look at some other causes as well. So bone mineral density testing in the DEXA, this is where we're looking at mineral per unit area of bone. Most of us think about T-scores for postmenopausal women, but in the adolescents and premenopausal, we're looking at the Z-scores. So one thing to note is that the athletes, because they're putting so much, like weight bearing on their bones, they're having an increased of that, increased weight bearing. They have an increased bone mineral density than non-athletes. So when you're looking at Z-scores, you want to, first of all, consider, is it an athlete that is a weight-bearing athlete or is it not? And then appropriately adjust. But if it's more than -2, that's normal according to our current sort of scales. In younger men, premenopausal women, and children, you cannot use your DEXA as that's the only thing. You need clinical history and others to identify osteoporosis. Sorry, I'm tripping over my words. Looking at vitamin D, well, vitamin D is inversely related to parathyroid hormones. So when we are checking vitamin D, I often check parathyroid because you want to look and also calcium, because you want to look and see what's causing it. If their vitamin D is low and everything else is normal, well, maybe it's just isolated vitamin D. But you want to make sure it's not another cause. So when you have a very low vitamin D, your PTH is going to elevate because it's stimulating osteoclastic activity in the bone. So you can try and elevate that vitamin D. If your vitamin D is really high, or not really high, but greater than 40, that's stable. So when you get labs on people, normal on the lab values is, I think, over 33, but we really aim to be over 40. With the calcium and phosphate, it enhances intestinal absorption of both. Intestinal calcium transport increases 45 to 65% of vitamin D increases. So the maintenance of all 3 of these is very tight, is very coordinated. And when we see the low calcium and phosphate, that's when we're thinking, okay, this isn't isolated vitamin D. This is we're thinking more rickets, and it can cause pain as well. So if you have somebody that has significant leg pain, this is why I often do check vitamin D, calcium, parathyroid, and phosphate. So again, how much is enough? I mentioned before that the labs say that more than that 33 and above is sufficient. But really, we think it has been shown that you have an increased risk of fractures in college and military recruits with less than 40 However, it has not been shown that supplementation decreases the risk. And a huge number of people, more than 1 billion people in America, have vitamin D deficiency, especially where we live, because you get it from the sun, fish, dairy, eggs. When you're supplementing, think about D3, and the goal is to aim for over 40. All right, calcium intake. So, growing up, it was always drink milk, get your calcium. But the role of calcium in strengthening bones is unclear. The studies show that you have decreased incidence of stress fractures. We know that diet sources are the best form because you don't have risk of secondary events such as kidney stones or cardiovascular events. And oral supplementation sometimes is needed, but dietary sources are best. So switching gears a little bit to hormones. So estrogen acts on our osteoblast and class in your receptor-mediated fashion. So it also has indirect effects on calcitonin and parathyroid cytokines and growth factors. So estrogen inhibits bone turnover. So, it's kind of important when we think we're talking about all of these hormonal cycles. And when I talk to kids about why I'm asking as a sports medicine doctor about their periods, I want to talk about how the hormonal cycling is really important in terms of bone growth and bone health. If you have lower levels, then you're not going to have as much bone growth and bone density enhancement as is needed. You won't reach your peak bone density. So the insulin-like growth factor 1 is also a bone trophic hormone. Oral estrogen decreases the level, but transdermal does not. So when you having people put on transdermal estrogen, it does not have effect on that versus when people are on oral contraceptive pills. Testosterone has positive effects on bone health, and Depo-Provera, which suppresses the axis, causes estrogen deficiency, which is how it works. But we have to be mindful of the effect it has on both. So when we're talking about lab tests, so if you have multiple stress fractures, high risk stress fracture, that's when we're talking about a full workup. So that's when we're getting a DEXA scan. We're looking at TSH, CBC, chemistry, FSH, well, obviously only for women, looking at their hormonal cycle, FSH, LH, estradiol, testosterone if you're worried about PCOS or if they're HER2, and DHEAS. So the other thing to be mindful of is these levels fluctuate depending on where they are in their cycle. So if somebody is on hormonal birth control, the labs aren't going to be good because it's going to affect their hormones. So you have to kind of look and say, all right, well, is there anything controlling these hormones? Where are we at before you're ordering the labs and interpreting them? Also, it's helpful to know kind of where they are in their cycle when they get their labs done. We're not going to go too much into RED-S because we've talked about it in other places, but it is really important when we talk about stress factors to look at energy availability, menstrual dysfunction, and bone health. It may be the first sign that they are actually on the spectrum of having low energy availability and having menstrual dysfunction, that they may show up with a stress fracture. So we're going to go over some cases, and then we'll kind of go through some risk grading. So 15-year-old basketball, track, cross-country athlete with recurrent left shin pain. So they had a inversion ankle injury in 2019. They didn't run track in 2020 because it was canceled, but they trained on their own. And then mid-2020, June 2020, 1 week increased pain with running. So all spring they had been running 20 miles a week. They then developed pain, none in the morning, but tender to touch, tight calves, walking with a limp, increased pain if runs. So then July, they were clinically diagnosed with a tibial stress fracture with a normal x-ray, treated in a tall boot, 5 to 6 weeks, formal PT, home exercise, cross-training, progressive turn to running. Everything sounds great. Returned to cross-country within 8 weeks, finished season well. No further workup done. Excellent. Sounds like everyone did everything right there, right? March 2021, started track. 2 weeks in, again, had pain. But the pain resolved shortly after rest. No pain walking, felt similar to the past pain, so she just wanted to check. They are running 15 miles a week, not missed any periods, 28 days, no unexpected weight loss, weight gain. Typical diet is, seems pretty good. Sleep 7 to 8 hours per night, no naps. On exam, has orthotics in her running shoes. She has some contralateral hip drop and valgus knee with semi-squat. Hop test shows some pain. Full range of motion. Just has some tenderness in that distal third of the tibia, about 2 centimeters. Get x-rays and everything looks normal. Bone scan. Initial imaging shows no increased blood flow or blood pooling. And everything looks symmetric. So this is flow phase, and then it ends at 60 seconds. 2.5 hour delay, we see some symmetric uptake of medial distal left tibia and symmetric uptake of bilateral anterior tibia. So you can see it's actually so hard to see on this, but you see it all along on both, but you can kind of see there's something a little bit right here, and a little something here and here. And the funny thing about these bone scans is that they're flipping around. So well, it looks here to me like this is the right, but it's actually, I guess, the left with their feet facing away. And on the bone scans, you can see where they are actually facing, because on the scan, it'll say left, right. Whole body delayed. So you can see that in the physes, you see stuff, and in the different growth centers, and then it has pooling in the bladder. So this is a whole normal uptake in growth centers, no asymmetry. When you get the spot images of blood pool and delayed, you can see a teeny little bit of increase in that, in that left spot. So she had a second stress fracture in 1 year. So we look and say, all right, biomechanically, are there any issues? Does she have any bone health issues, hormonal, training area, diet? Or what is the cause of this? So we did the full workup. Oh, so you do the full workup. Sorry, I thought it was going to show what we did. When we talk about fibular stress fractures, these are really a low risk, and typically there's something else going on, right? Because it's not a significant weight-bearing bone. So if you see this, for example, I had a patient that I happen to know pretty well who had multiple fibular stress fractures, and it turned out that she had a tarsal coalition, and that was what was causing her abnormal loading. So she ended up being able to get fit with an orthotic and kind of worked on her gait and becoming more forefoot. And she was actually able to run without having any surgery done. But I think if she had wanted to continue in college running, she would have had to do something. So looking at a younger kid, 9-year-old track runner with right shin pain, 3 weeks, noted pain along the front of her right shin while jump roping. It's worse with running and jumping, no pain with low impact activities. This was her first year in track, but did do cross country. But she does all this other stuff on the side, jump rope, running, biking, walking, hiking, trampoline, and whatnot. She's not had her period yet, picky eater. So examination really has bilateral pes planus with a pliable arch, minimal to no valgus knee, and just has pain on the hop test with loss of jump height, no visible deformity, and has some tenderness in the distal medial tibia metaphysis. So treated with the tall boot, weight bearers tolerated, cross-trained if no pain during or after. With her age and minimal increase in activity, chose to confirm the diagnosis. So this is a case where, because of the history being sort of like, it is important to officially diagnose it. If she does have a stress fracture, we'll go ahead and get labs. And because of, whenever I hear picky eater or very healthy eater, that always concerns me as well. And I have a very low threshold to get a nutrition consult. So she had a grade 3 stress reaction, mid tibial diaphysis. You can see the edema in here. There's no fracture line. And again, you can sort of see the edema in here. And then here's an example of, this is not that patient, but of that anterior tibial stress fracture. You can imagine if you ignore this and it keeps going, that they could have a break right through, and then that leads to them needing a rod. So we want to be very alert if we suspect this. So metatarsal stress fractures, you see those not infrequently you can see these in older women too. Like I see them in a lot of nurses that are on their feet all the time, or I mean, doctors, anyone, but I just happen to see a lot of them, anyone that's on their feet for hours and hours on end. So we are going to switch gears here. We have a few minutes, I hope. Yeah, good. To do some sort of bigger picture look at stress fractures. So looking at some cases, we're going to look at the different risk assessments and who gets to return to activity and why or why not. So looking at and these aren't all, well, you'll see, 15-year-old high school basketball player. So the athletic trainer referred because they had had recent weight loss in the last 9 months and it got down to a BMI of 17.8. They had not had a period for 6 months. They were overall tired, decreased performance, and just worried about gaining weight back. So when you look at this risk assessment graph, which is looking at all sorts of things, including low energy availability or disordered eating, low BMI, menarche, period, missing periods, bone mineral density, and stress fractures. And then you look at the cumulative risk, and it gives us a sense of what their risk factors are for going back to activity. So this kiddo has basically restriction or current disordered eating. Her BMI is low at 17.8. She's already had her periods, but she's missing them. And so if you count these 1, 2, 3, so she has 3 points. That throws her into this moderate risk factor area. So that means that she's permitted to play, but you want to practice, you want to decrease her practice time and make sure that she has sort of a contract signed with you, maybe the athletic trainer and coach, to make sure that she's following what you're giving her for restrictions. And then also making sure that she meets with a nutritionist and kind of follow her closely. So this patient did have a BMI, got her BMI up to 20, and was really reinforced by having improved performance. She was happy with how she was doing. She had menses return in 6 months and was able to go back to unrestricted play. So you look at a 20-year-old pole vaulter. Her BMI dropped from freshman to sophomore to junior year, but she was having great performance. She was doing really well. She was presented with some back and leg pain. She had had a DEXA, negative 1.2. She had had 6 periods in the last 12 months. So when you add all that up, you've got this really low BMI that puts you at high risk, and then some other moderate risk things. So that's 2, 3, 4, 5. So that puts her at the high end of provisional or moderate risk. And in this case, she's performing really well. So she created this contract limited to 3 days a week, spoke with the school dietitian, and really, had these goals that she was saying, okay, we can do. She met with the athletic trainer at school when she could, but he noticed that she was exercising in the morning. She was not following up with the dietitian, and she was not gaining weight. And then she went on to develop a femoral neck stress fracture. So now, when you throw in that stress fracture, it's a high risk one. Plus, she's, not doing any of the other things we've asked. So that's 2, 4, 5, 6, 7, and it puts her into the high risk management where she's not allowed to do anything. She ended up redshirting, and the good news about successful treatment is she was able to recover from a stress fracture. She got her bone mineral and her BMI up, and her menses returned, and she did end up going on to be successful. So when we think about these stress fractures, they are just one thing in the bigger picture, and we need to make sure that their energy availability is appropriate, that their bone health is appropriate, meaning that, you know, is this an overload on normal bone or is this normal load on abnormal bone? If kids, sorry, I take care of mostly kids. If our athletes don't restore their menstrual cycle, that's a big red flag sign. If they haven't got their menstrual cycle, that's a big red flag sign. And recognizing that oral contraceptives are not the first thing to do to get their energy back up and get their hormones in line. So for a sort of depressing or not as good of case, we've got a Division III college soccer player, presented metatarsal stress fracture, BMI 18, and has been missing periods, weight loss, wants to play, but isn't playing as well as normal. And when you add all those up, so restrictive eating, low BMI, low periods, and 1 stress fracture, she has 4 points. Puts her into provisional. Basically spoke with low energy availability as the cause for the possibly as the cause for a stress fracture, decreased performance, amenorrhea. Spoke to a dietitian, but you know, says she'll do it, but will she? Presents to did not gain weight by following up with the dietitian, did not get to her return to periods, and did improve her stress fracture. So when she went back to the doctor, they reinforced improving EA. They spoke with the athletic trainer and got a DEXA. She had no weight gain. She was pretty non-compliant. Her Z-score on the DEXA was negative 1.5. The athletic trainer said they were limiting practice, and the coach said she really can't hold her own. Center psychology. Well, unfortunately, this person failed to follow up and got cut from the team due to poor performance and lost to follow up. So when we see kids and athletes, and you know, it's when it's not an athlete, you don't have as much of a pull with other people involved. But when it's an athlete and you're concerned about disordered eating or any of the other background things that may lead you to have a stress fracture, really need to take the full picture approach, get everybody involved, get a written contract, or you know, you can call it whatever you want, but it's a treatment plan to make sure that they are doing everything that they need to get better. If you just treat the stress fracture and you get them back and you ignore the other stuff, they're either going to be back in your office or they're going to continue to sort of go down the wrong path and have it be a much harder treatment in the future. And remember, 90% of our bone density is occurs during adolescence. So, you know, before 25. So it's super, super important for us to recognize this. And this just might be one little red flag that happens. Have any of you guys done any contracts with anyone?
I have not.
I haven't.
Yeah, I haven't either. I think it's only really come up for me like 2 times where I think maybe a contract might have been appropriate.
Yeah. I think also, I mean, I've been with Oberlin, and in the past I was with BW, and I didn't see it as much with BW as I do with Oberlin, but I don't always feel like we have so many kids with eating disorders that are known, and it's almost like they're already being taken care of. And so I think it's easier to not take ownership of them, but it's still not the right way, I guess. We really have to be, you know, there's a couple of people that I've just in the years I've been with Oberlin that I see coming back again and again. And used to be that we had so many different people going in all the time. You didn't catch that it was a multiple one. So I do think it's really, for us, we've started keeping paper trails, and I think that helps a little bit to catch how many they've had and whatnot. And we now have a nutritionist, but it is super, super important. And I think when we see people in our office, it's okay to involve the athletic trainer at the school, the coach, whatnot. Obviously, you have to get the athlete's permission, but to make sure everyone's involved and knows what's going on. And then
Do you know of any resources, whether that's psych or nutritionists that are like I guess more affordable services to some of these athletes, because like BW doesn't really have anything on campus. I had
Yeah.
a girl yesterday who like recently said that her family like isn't financially supporting her, saying that it's hard to get into see docs for XYZ, and she has an underlying eating disorder, and I was trying to figure out where I could get her in.
So Nutrition with Brooke is who we use with Oberlin. She's great. I'm just showing you this here so you can kind of remember what it is. And then Forward Fuel is, I have to make sure it's the right one because there's also one that's Fuel Forward. So that's one. And then, so see Forward Fuel, and then there's one that's Fueling Forward or something. Yeah. My friend's daughter was working with this woman and very reasonable. And my friend's daughter, they live in Pittsburgh. And so, I just realized I can stop recording.